On behalf of the Clinton Foundation and the Johns Hopkins Bloomberg School of Public Health, I thank you for joining today's town hall on prescription drug abuse. This forum is a continuation of a conversation we began last spring, and the need for action is every bit as urgent today. Prescription drug abuse is an epidemic that has, in some way or another, touched virtually all our families and communities. Every day, as many as 45 people die from a prescription painkiller overdose. More Americans die annually from prescription drugs than motor vehicle accidents. The good news is there are many things we can do together to combat overuse of prescription opioids and to reduce its devastating impact on our nation. By focusing on the many facets of this epidemic, from educating physicians and patients about the risks, to arming first responders with Naloxone, to improving addiction treatment services, we can forge a clearer path to reduce death and addiction. But none of us can do it alone. And I'm confident the partnerships between the Clinton Foundation and the Johns Hopkins Bloomberg School of Public Health, and between all of you gathered today, will lead us to more effective, evidence-based solutions to this dire public health problem. So thanks for being part of the conversation, and my best wishes for a very productive event.
Welcome. My name is Joshua Sharfstein. I am the Associate Dean for Public Health, Practice, and Training here at the Johns Hopkins Bloomberg School of Public Health. We're about to have a great discussion over the next hour about the epidemic of prescription drug addiction. The Prescription Opioid Epidemic, an evidence-based approach, is a report that's being released today by the Johns Hopkins Bloomberg School of Public Health in collaboration with the Clinton Health Matters Initiative. For the next hour, I will be joined by three tremendous people talking about this report and issues of drug addiction in the United States. The first is Michael Botticelli, the Director of the Office of National Drug Control Policy in the White House. Director Botticelli has a tremendous record, even before he came to the White House, of leading on addiction issues in Massachusetts and around the country. He is the first public health drug czar, and it's tremendous that he is here with us today. I will also be joined by Shannon Frederoli, an associate professor in health policy and management at the Johns Hopkins Bloomberg School of Public Health. Professor Frederoli was one of the lead organizers and authors of the report that's being released today. And finally, I am joined by Dr. Christopher Jones. He is the director of the Division of Science Policy in the Department of Health and Human Services in the Assistant Secretary for Planning and Evaluation's office. He also has had a tremendous record working in the Office of ONDCP, in the White House, as well as at the Centers for Disease Control and the U.S. Food and Drug Administration. It's my pleasure to turn to Director Botticelli for some opening remarks. Director Botticelli has led the administration's efforts on addiction, and thank you for joining us.
Great, thanks, Josh, and it's great to be here today. And I also want to thank the Johns Hopkins Bloomberg School of Public Health and the Clinton Health Matters Initiative for convening this town hall and for your efforts to stem the opioid epidemic. Last year, several current and former ONDCP staff attended an event hosted by Johns Hopkins at which former President Clinton gave a keynote. This kicked off a year-long workgroup effort to bring some of the top experts in public health and policy together to address the opioid crisis. I am pleased to join you today as you release the recommendations. Before we get into those recommendations, I'd like to start with a short discussion of the opioid crisis so people watching today's event understand where we are now. According to the Centers for Disease Control and Prevention, of the nearly 44,000 drug overdose deaths in 2013, opioid pain medicines were involved in more than 16,200, and heroin was involved in more than 8,200. To frame this, drug overdose deaths in the United States outnumber deaths from firearms and motor vehicle crashes. Gunshot deaths, vehicle crashes, and prescription opioid overdoses are all preventable injuries, but only one, the prescription opioid problem, originates in the healthcare system. We can prevent this problem, and we must intervene. With the public health burden of this epidemic is unacceptably high. The mortality data actually show a leveling off in prescription opioid-involved overdoses after significant increases since 1999. Unfortunately, however, we have seen a dramatic increase in heroin-related overdose deaths, which nearly doubled between 2011 and 2013. We know the opioid crisis is far from over. We also know that the public health consequences of this crisis stretch beyond overdoses and include new cases of substance use disorders requiring treatment, babies born exposed to opioids who require treatment for withdrawal, in neonatal intensive care, and outbreaks of injection-related infections, including HIV and hepatitis C. Despite the progress we have made, these facts are a grim reminder of how far we need to go to make things better for people affected by substance use problems. The federal government is involved at many levels. Last month, I had the great fortune to travel with President Obama and Health and Human Services Secretary Sylvia Burwell to West Virginia, which has been especially hard hit by opioids and injection drug use. At the event, the President said, "We all have a role to play, because young people remind us these are our kids. It's not somebody else's kids, it's our kids. It's not somebody else's neighborhood, it's our neighborhood, and they deserve every chance. We've got to make sure that we're doing right by them and that we're taking this seriously." Bearing this in mind, I want to spend a few minutes reviewing the administration's response to the non-medical use of prescription opioids and the growing heroin and injection drug use problem. In 2010, the President released his inaugural National Drug Control Strategy, which emphasized the need for strong action to address opioid use disorders and overdose. The following year, the administration released its National Prescription Drug Abuse Prevention Plan to establish our best options for addressing the nation's overdose and overprescribing crises. Since then, we have been working with our federal partners and stakeholders and have made much progress toward many of the goals established under each of the pillars: education, monitoring, drug disposal, and enforcement. I am pleased to read the Clinton report and see how many recommendations of our plan your report mirrored and built upon. For example, supporting mandatory prescriber education, requiring prescribers to check the state prescription drug monitoring databases when writing an opioid prescription, and encouraging pharmacies to help with the disposal of leftover drugs. A few of your recommendations also appear in this year's National Drug Control Strategy as new promising practices, for example, patient and pharmacy restriction programs. In the time I have remaining, I'm going to talk about two promising approaches to improve the lives of people actively using heroin or prescription opioids for non-medical reasons. These approaches, highlighted in our 2014 strategy and Secretary Burwell's opioid initiative, involve expanding and improving access to the opioid antidote naloxone and improving access to medication-assisted treatment. Naloxone is needed to help reverse overdose deaths. All across the country, I've heard from federal, state, and local law enforcement that we cannot arrest and incarcerate our way out of this epidemic. I have seen unprecedented partnerships between public health and public safety. From one small police department in Quincy, Massachusetts, we now have thousands of police officers and other first responders who use naloxone to reverse overdoses. Medication, when combined with behavioral treatment and recovery support, has shown to be the most effective treatment for opioid use disorders. Medication-assisted treatment increases a chance a person will remain in treatment and learn the skills and build the networks necessary for long-term recovery. The President's 2016 budget request include millions of dollars in additional funding for treatment and overdose prevention efforts. The Health Resources and Services Administration recently offered $100 million in supplementary grants to support medication-assisted treatment expansion in health centers around the country. HRSA is also supporting naloxone in rural communities alongside a program for other life-saving equipment for first responders. And SAMHSA recently awarded an additional $11 million to support medication-assisted treatment targeted capacity expansion in high-need states. This year, we have also strengthened federal contracting language to ensure that there is access to medication-assisted treatment and that people on medications are not categorically excluded from federally funded services. But no matter where I go, I hear about the role that shame and stigma continue to play in keeping people from seeking care. Having access to treatment is utterly inconsequential if people are too ashamed to ask for help. I believe that those of us who have lost loved ones and those of us who are in recovery from substance use disorders must speak up to defy the stereotypes and strike down the stigma that keeps too many people from obtaining help and moving to long-term recovery. Jurisdictions need to begin working now to implement public health programs such as syringe exchange services naloxone, and treatment services rather than wait for public health emergencies. A smart public health approach to both HIV and prescription drug crises require us to take action now. That is why, as part of the West Virginia event, President Obama, Health Secretary Burwell, and I announced 5 unique private sector commitments to supplemental federal and state efforts to expand access to overdose prevention and medication-assisted treatment. First, more than 40 provider groups, including the American Medical Association, are committing to double the number of prescribers able to offer office-based buprenorphine and the number of providers that prescribe naloxone. Second, the drugstore chains CVS and Rite Aid have committed to expanding naloxone availability. The Fraternal Order of Police will distribute wallet cards to all of their members to recognize the signs and symptoms of an opioid overdose. And lastly, the Harm Reduction Coalition is more than doubling the number of free overdose reversal kits they plan to distribute in 2016. As part of this event, the President issued a presidential memorandum to the heads of all executive agencies, which will ensure that the government is doing all in its power to align, identify, and address barriers to medication-assisted treatment, including providing support through its health programs and insurance coverage. We know that there is no one-size-fits-all solution to this problem. Solving the opioid crisis requires the active participation of multiple agencies, levels of government, as well as the private sector. It requires cooperation among public health and public safeties, private enterprise, education, and philanthropy. That is why I'm honored to be part of this forum today as Johns Hopkins unveils the recommendations from its expert panel with support from the Clinton Foundation. As the President said, every member of the community has an important role to play. So if we all play our part, working together, we can accomplish so much more. Thank you.
Great. Thank you very much for those inspiring words and for your leadership. You have been able to communicate on these issues and set policy across the country, engaging with people who are suffering from addiction to people all across the political spectrum. We really thank you, and thank you for joining us.
Thanks, Doc.
I want to make sure that everybody knows that they can join the conversation. We're on Twitter with the hashtag RxTownHall. That's the hashtag RxTownHall. Next, I want to turn to Professor Frateroli. Shannon, tell us about this report that's being released today. What was the process that went into it, and what are its major findings?
Sure, I'd be happy to. The process really started with a group of us here at the school talking about the problem of prescription opioid overdose, misuse, and abuse, the existence of evidence, the research that's coming out on this problem, and the real need to make sure that that evidence is translated into actionable recommendations and policies that can actually help people. We looked around the room and realized in fairly short order that we could benefit from this process by calling upon the national thought leaders on this issue, bringing them together and really reviewing the evidence in a thoughtful, comprehensive way in order to inform recommendations. And that process led to the May 2014 town hall event and meeting that included about 40 experts from around the country from a variety of disciplines, including medicine and law, people from industry, people from community, people from injury prevention, to really bring a comprehensive approach to solving this problem. Out of that meeting, we agreed on 3 guiding principles to take us forward that included making sure that we respected and realized the need for people who are in chronic pain to have safe access to these drugs. We wanted to make sure that our efforts, again, were comprehensive in nature so that we could take a full approach to this problem. And we also wanted to make sure that we came away from this process with some real actionable recommendations so that the science could inform how policymakers, community members, and stakeholders in this process could act to stem the tide.
Great. Now, you are the Associate Director of the Center for Injury Research and Policy here at the school, and that center works on seat belts and all kinds of other safety issues. How does that mentality translate to the epidemic of prescription drug addiction?
Well, in injury prevention, we've had a number of successes with intervening in problems that cause injury and death across the population. So we're very focused on understanding the problem, identifying interventions, and bringing those interventions to the population. And again, it's an approach that starts at the manufacturing stage and ends at the community stage with everything in between. So again, a comprehensive approach to figuring out how science can best inform solutions to some of our most pressing public health problems.
Great, thank you. I want to turn to Dr. Jones now. I'm interested in your perspective, given your experience in public health at the Food and Drug Administration and now at HHS, and what you think some of the most important recommendations in this report are.
Sure. And thank you. And I agree with looking at a comprehensive approach. And I think it's difficult to pinpoint a particular single recommendation because I do think they all work in concert together. But as Director Botticelli said, really focusing on medication-assisted treatment, access to addiction treatment, naloxone, and prescribing practices, the three areas of the Secretary's initiative, I think line up quite closely with the recommendations in this report. I think fundamentally, the one that really rises to the top for me acutely is access to addiction treatment. So we have an evidence-based modality that is not being provided and has not historically been pursued in the same way that we've pursued other evidence-based treatments. And I think part of that is the stigma issue, part of that is providers understanding what it is and patients understanding what it is. And so I think the addiction treatment section of this particular document provides a lot of nice recommendations about how we can get to where we want to go. So it includes education and awareness. It includes looking at policy change for coverage and providers who can provide this service. And I think doing that in concert with all of the other actions is really can help us get to where we want to go. And when we look at the deaths, I mean, that's the most preventable outcome and the outcome that we want to prevent the most. And we look at who's dying, a significant fraction of those people have an underlying substance use disorder. And we know from the data that providing medication-assisted treatment for those patients can reduce their overdose risk, and it's not being done.
So let me ask you this question on that point. There are a lot of places that resist medication-assisted treatment, and they think that the best thing is for someone to go cold turkey. In some cases, it's people who succeeded in going cold turkey, in their words, without any assistance for medications. Tell us about what the federal government is doing to engage with organizations and people who have very strongly held views on that subject.
So I'll start. I think some of this has actually come from the addiction community in general, and particularly those who have had a different path to recovery. So part of it is kind of changing the mindset of even the recovery movement and the recovery field to understand the effectiveness of these medications. But particularly at the federal level, I believe that we have an obligation to promote this as the standard of care. So again, of how we look at changing our contracting language. Mm-hmm. And I think it's particularly acute within our criminal justice settings that we've seen a real reluctance to embrace medication-assisted treatment, even though we know those programs serve a lot of people, whether those are our jails, our drug courts. We have to increase. So part of what we've been doing is ensuring that our federal contracting language ensures that people with opioid use disorders will have access to these medications, as well as within our treatment programs. But the third point, we have these two great medications that were designed to be delivered in primary care settings, not in specialty treatment programs. And unfortunately, we have too few physicians who have taken up prescribing of these. So part of what we're promoting and part of the private sector commitments was looking at how do we increase the number of providers who are able to prescribe these medications, as well as increasing the capacity within our primary healthcare system, particularly our community health centers. I think we all agree that it's really underutilized infrastructure that we need to expand addiction treatment. So that's why I think we were thrilled that the Secretary announced additional dollars for community health centers to expand access.
It's very important. I can say in my own experience, I've run across a lot of doctors who are initially reluctant to get into it, but they find it very satisfying because they're really helping their patients, as well as the fact that it's easier to treat the underlying condition. And there's evidence that you can treat HIV, chronic liver disease, and other conditions better if the person is also in effective addiction treatment.
I think you bring up a good point that we know that many people with substance use disorders have comorbid medical conditions as well, and particularly HIV and viral hepatitis. And being able to get holistic, integrated care in one setting becomes really, really important, because we know that to get good outcomes in any one of those domains, you have to be looking at good treatment across those domains.
Great. So we are starting to get some questions in. So I will ask the first one. Someone emailed that she suffers from illnesses and injuries that have stolen the quality of life away from her. She found out that her pain medicine is going to be cut back or terminated at the next visit to the pain doctor. And it is not being taken away because I have ever abused my medication or lied or deceived or stolen or sold it. So why am I going to be punished? And I think this question reflects the concern, certainly, that patients with pain have, that the focus on the epidemic of prescription drug overdose may adversely affect their access to therapy that they need. And maybe, Shannon, how does this report balance those?
So certainly that was one of the guiding principles that we took on from the beginning, recognizing the importance of these medications to certain people within the population who are living with chronic pain. One of the ways in which this report addresses that is through our first recommendation, which has to do with prescribing guidelines. So making sure that physicians are well-trained and have access to people with experience in prescribing these drugs and in treating pain is an important strategy for moving forward in a constructive way and using these drugs safely.
Great. And Dr. Jones, there's obviously a balance. On the one hand, it is very important for patients to have their pain treated, but on the other hand, there's no question that it's been overprescribing in certain settings that has fueled the epidemic. How does the federal government balance those different issues?
So similar to the work that's been done here, I think that from a federal perspective, we also appreciate the need to balance both sides of the issue and have pursued policies that attempt to do that. On the side of, certainly there's a fundamental lack of education around appropriate pain management, not just in the use of opioids, but in multidisciplinary care, use of non-pharmacological interventions or non-opioid interventions. And so we've made investments, for example, the National Institutes of Health Pain Centers of Excellence have funded health professional schools to develop curricula on pain management, because it has to happen in concert with the work that we're doing around opioid prescribing guidelines that CDC is currently working on, or using PDMPs. And under the Secretary's initiative, the first aspect is really providing clinicians with the education and tools that they need to make informed prescribing decisions. I think it's often tried to simplify down to you either have access to opioids or you don't. But I think the data reflect that some people who've had plenty of access to opioids have not gotten quality pain management. So I think it's really about what's the right modality or modalities for a particular patient. In some cases that may be opioids. In some cases it may be taking them off of opioids and getting them onto a therapy that will be better for them.
Now, you are a pharmacist, is that right?
Mm-hmm.
Does the pharmacy profession have a role to play in helping with effective management of pain, and can you talk about that?
Sure, absolutely. I think pharmacy for many years has seen itself in a more of a policeman's type way of, we're not going to fill the prescription, or we're going to call the doctor and ask, is this right, and then we're going to fill the prescription. And I think with the advances of prescription drug monitoring programs, drug disposal programs, and even particularly Naloxone, there really are opportunities for pharmacists to take a leadership role. And in Naloxone, for example, many states are passing legislation or through public health authority, collaborative practice agreements or standing orders where pharmacists can initiate Naloxone prescriptions. It's really a tangible opportunity for pharmacists to engage with patients, to educate about opioid safety, to have patients understand, I'm taking this medication for pain, but it has serious risks. This is a medication that can help mitigate that risk. So I think there really are a lot of positive opportunities for pharmacists.
Director Botticelli, I don't know whether you've heard sentiments like this as you've traveled the country. How do you respond to that?
So I would echo what Dr. Jones said, that part of our strategy all along has been looking at a balance in terms of making sure that people have appropriate access to pain management strategies, but also ensuring that we're really diminishing the prescribing behaviors for people who don't need them. And I think it starts with education. I believe that we don't want to have, I hear stories like that and it makes me cringe that, if this person is doing well and functioning, not developing a substance use, there's no, I'm not a doctor, but it sounds like there's no clinical case here for removing that person. So I think we need to be careful that the pendulum doesn't swing in the in the opposite direction. And, I'm really glad that the report kind of struck at this balance that we need to strike. I do think that, there are opportunities here, not just around looking at opioid prescribing, but again, as Dr. Jones said, looking at alternatives. What are the alternative therapies that we can implement for people who have pain, to really look at beyond just opioid prescribing?
Great. So one of the questions that came in from Virginia was, what is the most important thing for a patient who is prescribed an opiate pain medication for the first time to know?
So I think it really starts with having the conversation with the provider. So really, what are the expectations of pain treatment? Why am I being prescribed this? What are my goals? And then understanding the risks. What other conditions or drugs do I have that might increase my risk for overdose? How do I store these products appropriately? How do I dispose of them appropriately? And certainly understanding about not sharing medications. We know from the National Household Survey that a common source for non-medical use is friends or family either giving, sharing, or selling to others. And that certainly is contributing to the public health problem. So I think appreciating the risk and then really fundamentally understanding what are the goals of treatment. Why am I getting this? What is it supposed to do? What does it not do? And then how do I monitor and follow up?
Right, and patients should know when it's time to stop taking them. Sometimes it may not be that clear. I had a tooth taken out and it's here's some pain medicine, but when should I stop? When should I take it, and when should I stop, and then get rid of it when it's gone? I mentioned my tooth because one of the questions that we just got was about dentists, and is there a focus on dentists in terms of maybe giving a few extra pills so that the patient doesn't need to be in pain and come back, but is that an area of outreach? Is this a report comment on it? And maybe if either of you want to talk about the dental profession.
So we didn't specifically look into the dental profession as a provider that we singled out, but certainly thinking about prescribing guidelines generally for all providers is where the report would speak to that issue generally.
One of the areas when we look at who's prescribing medications, dentists are often very high on the list in terms of the number of prescriptions. And we were actually able to work with the American Dental Association as part of the commitment to train physicians. I think we understand that this is not just physicians, but dentists have a role to play as well. So, it's a particularly important group to focus on. But I do think, and I've heard a number of stories where in, I think, well-intended ways to treat pain, that people are getting far too many daily doses of pain medication for dental procedures when a patient might do very, very well on extra strength Tylenol and maybe only need 1 or 2 days of prescription pain medication to handle their pain. I will say I've had my own experience as a person in recovery with a dentist who tried to offer pain medication, and that's why education becomes so important in terms of understanding kind of what's the appropriate pain, but also who might be at risk for these pain medications.
So here's a challenging question. States have implemented prescription drug monitoring programs, and oftentimes they allow doctors to know if patients are having trouble with prescription drugs. They may be doctor shopping, they may be, misusing the drugs. And generally speaking, there was a paper that was recently published. Those programs are very focused on reducing those prescriptions and kind of stopping the people, and not as focused on reducing overdoses or assuring that the individuals get into treatment. And I guess maybe I would ask you, Dr. Jones, in the context of prescription drug monitoring programs, what is the federal government doing, or what do you think is important for doctors and other prescribers to do when they see that somebody is running into trouble? Is it enough to say, I caught you, get out of my office?
Well, I think, again, it comes back to education. So, if you have this tool to provide information and you don't know what to do with the information, then it's not going to be maximally impacted. So I am a pharmacist. I'm pretty good at identifying people who are misusing substances, and certainly the PDMP can help with that. I wasn't well trained in what to do next. So I think education is really fundamental in how do we do this? We certainly know that discharging a patient from the practice, if they have an addiction, doesn't change the fact that they have an addiction. And certainly it doesn't get them into treatment. So I think we have to think about how do we connect in education around the use of PDMPs as well as where is treatment available? Do primary care providers know the treatment resources in their community? Are they data wave to provide buprenorphine, or have they been educated on using naltrexone? It gives them tools that they can use to do this. Or do they have training on brief intervention just to have the conversation? Because I don't think it does public health generally no good if you just say, you're out of my practice. It doesn't solve the problem. It perpetuates the problem. So I think there's really opportunities to link up sort of the upstream concerns around prescribing with connecting patients into treatment.
Great. And Dr. Botticelli, are you concerned that if that gap isn't crossed, that you could be pushing people closer to heroin and other illicit substances?
I do. I think we miss multiple intervention points with people who have misused prescription pain medication and certainly prescription drug monitoring programs and their ability to identify people and refer people. I think we're seeing some innovative programs that are happening at the state and local level where a pharmacist or prescribers who identify someone are able to refer to a treatment program. And so they've really, I think, cemented that relationship between prescribers and treatment programs to accelerate and increase the probability that someone's getting into care. I do think that part of what we know around the increase in heroin use is that 4/5 of newer users to heroin started by misusing pain medication. So again, I think that while we know we need to diminish the supply and the prescribing, we also have to make sure, again, that people are getting access to care and treatment, because we don't want to have an unintended consequence of basically people moving to heroin because it's cheap and readily available in many parts of the country.
So it's really an opportunity for intervention.
It's an excellent opportunity.
So I wanted to remind everyone that you can join the conversation at #RxTownHall on Twitter. So the next couple questions have to do with naloxone. So Mike from Baltimore asks, why is naloxone so expensive? And this is creating a drag on budgets at different levels. It's making it harder to do big programs where pharmacists can give out the naloxone. Do you have any thoughts about that? I know, Dr. Jones, you and I worked at FDA. It's an interesting topic when even generic medicines like naloxone wind up pretty expensive. Is that something that you all are looking at, or any comments?
So I think it's really unfortunate that the manufacturer of naloxone decided that they were going to triple the price of naloxone. And we know that many of our programs are operating on very tight budgets, and that tripling in price will diminish the number of kits that they have available. One of the things that we've been trying to do at the federal level is make sure that either existing grant programs or new grant streams are available for naloxone purchase at the community level. And I'm happy to say that we do have some limited money, and part of the president's budget proposal in FY13 or FY16 will continue to look at additional dollars to support naloxone purchase.
Great. I can say that here at the school, we are looking at some of these issues of pricing and generic and prescription drugs, because it is not just with overdose, but other conditions that people have run into some challenges recently.
I'll say, one of the interesting things that came out of looking at these commitments is that a wide group of stakeholders, so governors, mayors, others, have entered in a collaborative purchasing agreement so that they could actually band and leverage their collective purchasing power for both naloxone and opioid treatment medication. So I think it was one of the more innovative things that came out of our work is different government entities coming together to form a purchasing collaborative to hopefully drive down the prices of some of these medications.
I'll just add that I think on the sustainability side for naloxone, looking at pharmacy reimbursement as a model to offset some of the costs so that the limited grant funds can be used for those programs that don't have access to that. So as we expand coverage for populations, as more and more private and public payers cover naloxone products that become available, those resources can be used in that space to capture that population so that the limited resources can be used for other populations.
In other words, making sure that the extra funds are used for people who couldn't get naloxone any other way. And with respect to that, who should be getting a naloxone prescription or a naloxone dose? Maybe not a separate prescription. on the one hand, you want to save it for people who may be at the highest risk of overdose. On the other hand, you don't want it to be kind of a little bit of a, not exactly stigmatizing, but you don't want it to be like this big moment, like, are you at such high risk right here that you're going to get the naloxone? And I know some states are looking at much broader access, even for anybody who's getting opiates. So are there thoughts that you all have in this, or Shannon, do you want to comment with respect to the report?
Sure. So one of the recommendations with regard to naloxone that the report makes is to look at co-prescribing naloxone with certain opioids at certain doses. So that's one of the things that we looked at. It's one of the things that we recommend, actually. And it's one of those areas in which I think we can get very specific where this resource should be targeted to particular populations that are receiving these high doses of opioids.
I think there is general consensus of certain populations, so people who have an opioid use disorder or who are in treatment for an opioid use disorder, people who've previously overdosed. A previous overdose is probably the strongest predictor of a future overdose. Mm-hmm. So people leaving emergency departments who've just come in for an overdose, people leaving the criminal justice system are extremely high risk when they're leaving. So I think there are certain populations that it's pretty clear, and most people would say, yes, that makes sense. We had a panel on this very question at the FDA meeting back in the summer that was discussing broader access to naloxone. And I think within the patients who are receiving opioids for pain, there's not yet consensus. There certainly are conditions where you have underlying respiratory problems, you're on high doses of opioids, you're prescribed an opioid with a benzodiazepine, you have other risk factors where it seems pretty clear that, co-prescribing is an option. But the idea around, is it destigmatizing to just offer it to everybody who gets an opioid? I still think those are outstanding research and policy questions.
Great. Methadone is a long-standing treatment associated with fewer overdoses and better outcomes for patients. Yet you don't hear a lot about expanding methadone in general, and there are a lot of federal regulations that pertain to methadone. And so we had two questions on methadone. One is it time for Medicare to cover methadone treatment? The other is, why not more emphasis on methadone as part of the federal government's efforts on this issue?
So let me start. And part of what we've been advocating for is access to all the FDA-approved medications. We need to have multiple tools in the toolbox, and particularly different medications, because they work for different people in different circumstances, and need to be able to transition people to do that. So we need to have those toolbox. Methadone has been around for over 50 years, one of the most highly evaluated and proven successful drugs that we have. I am still, quite honestly, surprised by the lack of understanding of methadone, what it is, and its success rates. And part of my job is to educate legislators, folks in Congress, and the community about doing that. But one of the issues and one of the outcomes of the presidential memorandum was to look at every federal insurance program, so Medicaid, Medicare, federal employees' health insurance, and other programs, to identify any potential barrier for all of the FDA-approved medications, and to implement an action plan to diminish those barriers. So, we do need to make sure that if we're saying that they're the standard of care, that our federally sponsored insurance programs are reflecting that in their policy and payment.
Yeah, I would say as a pediatrician, one of the most heartbreaking things that I've seen is when the pregnant mother is on methadone and is able to continue on methadone through the delivery, because that's the recommended medication, and then there's not the opportunity to continue treatment, and then the mom may relapse and actually lose custody of the child, and it's sort of everybody loses.
Yeah. But I will also say, in addition to Medicare, we also have to work with our private insurers, who most often really don't pay for many of the medications that we have out there. So again, this is a collective effort, not just around federally sponsored plans, but ensuring that our private insurance plans are meeting their obligations under parity to make sure that they're giving out all of the FDA-approved medications.
Great. I want to switch to a question that we got from Florida, which is amphetamine abuse is rampant among university students. How can we educate about its dangers without attacking prescribers, which I guess they probably mean Twitter, you don't get a lot of characters. I would say probably means without people who legitimately may need, for example, stimulant use for attention deficit hyperactivity disorder or other conditions. there's an awful lot going on the opioids. And anything you would want to respond on this? Is this something that you agree with is a major challenge out there?
I do think it's a major challenge, and I think there are some parallels here as it relates to prescription pain medication. And again, I think there's this balance between making sure that people are getting appropriate access, and I know that there are many, many people who need to be on those medications do really well. But I also think that there is, and I think the misuse can come from sharing your medication. So we know sometimes that people think because something is prescribed by a physician that it's not as it doesn't have the health implications. So I think that there are some parallels here and some lessons learned around the prescription pain issue that really affect other issues. And particularly, I think a stimulant medication is a good example of, good education, making sure people understand the dangers, making sure that we're telling people, that they shouldn't be sharing medications with other folks. In this case, people are usually taking them for what they think are performant when there's clearly no evidence to support that the drugs do anything to enhance people's performance.
So hopefully better work on opioids may actually have some beneficial consequences for prescribing of other drugs as well.
I do, and I'd be interested, if Shannon thinks that there's parallels here in terms of those kinds of issues.
Well, certainly a lot of the opportunities that we've already talked about, there's certainly parallels. So, the earlier questions about what should patients know when prescribed drugs and the importance of having patients engage with their providers in the risks and benefits of the drugs that they have is an opportunity, again, to just have more knowledge, more education, more awareness about the risks and benefits for opioids as well as for amphetamines. So certainly some parallels and some opportunities there.
Great. And you can still join us at #RxTownHall on Twitter. We're getting a lot of different tweets in so far. We've talked about pharmacists, dentists, doctors, and now I have a question from a nursing student that came in from Twitter, which is, I want to be able to prescribe buprenorphine as a nurse practitioner. Will I be able to? What do we think?
So I'll start. Again, this is part of our overall efforts to look at increasing access to buprenorphine. Unfortunately, that the Data 2000 law actually precludes anybody other than physicians to be able to do that. There's actually legislation now sponsored by Senator Markey called the TREAT Act that would expand who could prescribe buprenorphine in this situations. So I think there is significant interest, legislative interest, on expanding who can prescribe these medications.
Great. In addition, one question came in is it the case that buprenorphine or methadone alone is an effective treatment, or do patients also need other kinds of services? And maybe as we think about that, what is the right set of services that individuals should be receiving? Dr. Jones?
Yeah, I generally think, these are patients who are coming in to receive medication-assisted treatment, as we've already discussed, often have many co-occurring conditions. So giving them buprenorphine, methadone, or naltrexone is going to address one side of it and potentially stabilize them to address the other issues. And I think it's important to think about counseling and other diversion mitigation measures as well. So drug testing, checking the PDMP, those types of things to ensure that there's high quality care that's being offered. The data, show that there's clearly a benefit in providing the buprenorphine or the methadone or naltrexone. But I think we get our most robust response and sort of a holistic patient response when we have additional behavioral health and medical measures that are added to that.
Great.
I think the other thing is, we want people to have healthy, happy lives. And medication is a strong role in ending their use of those medications. But they need all of the other counseling recovery supports, being part of a recovery community. Mm-hmm. We want people to be happy and healthy, and that has to be part of the treatment and recovery plan, in addition to the medication.
It's certainly not either or.
It's not, no, but they are clearly play a huge role in keeping people engaged in care and increasing the chances that they'll get to long-term recovery.
Great. One of the questions is about benzodiazepines, another class of medicine. So we're talking about opiates, the role of amphetamines, and benzodiazepines are often co-prescribed with opioids, and there's concern biologically that they can work in concert with opioids and cause overdose. Is that a concern that you share, and is appropriate benzodiazepine prescribing a top priority in the context of prescription drug addiction?
So I think in any guideline that around prescribing of opioids that's come out in the last few years is generally a pretty strong statement of avoiding prescribing benzodiazepines with opioids whenever possible. And I think the data are pretty strong on the contribution of benzodiazepines in opioid-related harms. So if you look at the mortality data, almost all of the increase between 2006 and 2011 was where opioids and benzodiazepines were involved in a death. So it's the most common co-occurring drug in opioid-related deaths. About 30% of deaths involve a benzodiazepine. Of 30% of opioid-related deaths involve benzodiazepine. So I think it's incredibly important. There certainly are clinical situations where it's appropriate for both of them to be prescribed, but I don't think that there's a full appreciation of the potential synergistic risks when you look at a number of studies that have looked at what are the risk factors for people who die. The combination of those products outweighs almost all of the other risk factors, whether that be seeing multiple doctors or multiple pharmacies or high doses. It's really the combination is the extremely strong risk factor.
So as you think about that and the need for doctors to understand, we've talked about prescribers in general to understand. We've talked about the importance of understanding how to respond to the PDMP if it shows a signal, the importance of the co-prescribing issue, the importance of only prescribing what's needed. But also the importance, as you said, of treating people's pain, and making sure that you're not inappropriately cutting people off because of a misunderstanding about this. What are the ways that the medical profession is responding? You mentioned the AMA is increasing, is supporting more doctors to prescribe buprenorphine, but what are the professional societies doing to emphasize education? I'll say in Maryland, one of the things that the Board of Physicians did for the first time ever made a requirement that every licensed physician at least have an hour, 1 hour of time on appropriate prescribing. And I wonder if you could talk about the voluntary, professional, but also the maybe more required kinds of educational activities. And maybe, Shannon, is there anything you would talk to in the report on education?
Sure. So certainly more generally, and this falls again within the prescribing guidelines recommendations, there's a call for specific training residency programs in pain management. So that's a very tangible recommendation that has come out of this process that speaks to the need for education on this issue in particular.
So a number of states have passed similar requirements for mandatory education about appropriate prescribing. Under the White House commitment, the 40 or so provider groups made a commitment to educate 540,000 providers on appropriate pain management as part of that commitment, in addition to the buprenorphine commitment and naloxone commitment that were mentioned earlier. In talking to those organizations in the build up to the announcement and continuing to engage with them, they are increasingly offering pain-related or substance use disorder education at their annual meetings. It's increasingly being asked for by their constituency. So I think they're working in those ways to provide that on a voluntary basis.
Right. Now I'm going to ask you a tough question, which is in Maryland, this requirement took effect, and I went to one of the trainings, and it was packed on a Saturday morning, a beautiful Saturday morning, and the teacher, who I happen to know, asked whether people were there because of the requirement, and about half or more of the people raised their hand and said that's why they were there. And this is an area where you might say, well, the people who are asking for the training, that's great. I'm also worried about the people who aren't asking for the training. And one idea that's been bandied about at the federal level is requiring some degree of training to get the DEA number. And where does that stand as an idea?
Sure. So we have long supported mandatory prescriber education for precisely the reasons that you articulated. I think, again, we're 10 years into this epidemic and we have, extraordinary numbers of people dying. And I think that, requiring prescribers to take a minimal amount of pain education is well worth the couple of hours that you might spend on a Saturday morning doing that. I also think, too, that some of these issues go deeper and that we really have to look at not just pain education, but substance use education in general throughout our health professions. And, I think there is an opportunity here where we have organizations coming to the table to look at how do we embed, good curricula around substance use education in a wide variety of health professions, because people and practitioners don't get very much training on substance use issues in general, let alone pain prescribing. So I think that we have the opportunity now to really look at not only better pain prescribing, but also increasing the understanding and the clinical skills of folks to understand and do a better job around substance use issues in general.
Great. A couple questions have come in about drug disposal. Here in Baltimore, there was an announcement in the paper today that the health commissioner, Dr. Lena Wen, has worked out with the police department, allowing people to bring in their prescription drugs to any police station. There are take-back days. How important is this as part of the overall picture? And are there particular advice that you would give to patients who may have pain medicine at home? Shan, do you want to start from the report?
So I think that this is again, we've used the word opportunity a lot throughout this conversation. I think that this is a tremendous opportunity to really make an impact with very little effort on this issue. How many people who are listening in right now can sort of think about their medicine cabinets and how many expired or, recent prescriptions that they have, but you just don't know what to do with them, so you sort of hang on to them. If we could, within our communities, through our state governments, through city officials like Dr. Wen, through federal assistance, establish known places where people can dispose of their pharmaceuticals, we would go a long way toward getting rid of some of the excess supply that's out there. So I think this is an important opportunity to look at.
Right.
I would agree. When you look at the data, 70% of people who start misusing a prescription pain medication are getting them free from friends and family. So we're not talking about people who are buying them on the internet or buying them on the street. As I said, this is an epidemic started at the medicine cabinet. And so I think looking at moving away from some of the dedicated take-back days, that the DEA released new regulations that allow for much more ongoing disposal. And so part of our work at the federal level is to continue to support kind of these continuous take-back programs and not just relying on dedicated DEA-sponsored take-back days.
And what about pharmacies, Dr. Jen? Do you think that the time will come? I mean, people don't necessarily think about medicines in the police department. Do you think there's a time when people will be able to drop off drugs back at the pharmacy?
So certainly under DEA's rules, it's a possibility. I think the question still is who pays for it and how is it financed. And so some localities have passed ordinances to require pharmaceutical companies to pay for it and have pharmacy disposal. I think there are examples of non-controlled substance disposal programs that are based in the pharmacy that have been very successful, that pharmacists see it as part of the work that they do. I think it presents an opportunity to have a conversation, especially if a patient is coming back and they're getting rid of something. It has the opportunity to have that conversation of, what was going on, why didn't you take it, whether it's a controlled substance or not. I think it adds an additional conversation between a healthcare provider and the patient.
Now, is it absolutely necessary if someone's got some opiates at home that they really want to get rid of, that they find one of these take-back programs, or is it acceptable, for example, for people to flush it down the toilet? Dr. Jones?
So current recommendations are for particular products, and there's a list that FDA has put out that because of sort of an immediate risk of having this product in the home, flushing is recommended. But I think the goal is that once disposal becomes commonplace, and there are plenty of areas to do it, whether that be pharmacy-based or mail-in or dropping off at a police department, that those recommendations would be changed because it would be the social norm to just take back leftover recommendations. I think looking at it from a comprehensive perspective, as the report does, hopefully we'll get to a point in the future where we don't have this excess of drugs, that people are prescribing the right amount for the condition that's being treated.
People can put it in the toilet and not feel guilty about it if they flush, basically. It's not the worst. It's not the worst case scenario, because a lot of opiates that are taken wind up in the toilet.
But I think one of the things that the report talks about is kind of engineering here, right? And so one of the, I think, bright spots is there are now these really low cost drug deactivation packets that people can buy that are really highly, so there's really not a need to flush them down the toilet. I mean, I know, $3 or $4 can be prohibitively expensive for some people, but we do have these great new deactivation devices now that, people can put the unused medication in the pouches and dispose of them in the trash.
So avoid it if you can, but in the end of the day, if that's what's needed, that's okay. Let me ask a challenging question at the end as we're wrapping up. There are individuals who are, for example, users of intravenous drugs who have pain and they need to have the pain treatment. And conversely, there are people who have started out with a very serious pain disorder and move a true pain disorder or some condition that causes true pain, and they do wind up with an addiction. And to a certain extent, the people think about these two issues as different categories of people, but there are a number of people who really are in the middle. We got a question from one of our students here at the school about individuals who use intravenous drugs and the challenges they have getting their pain treated. How do you all think about that? Is there a role for better education at that juncture, better thinking, at that juncture between pain and addiction? I'll open that up to anyone.
I think fundamentally, a patient should be treated with compassion and empathy, in that the medical conditions that they have at the moment that they're seeking care should be addressed. I think on both sides, if a patient has a pain condition and they were prescribed opioids and developed an opioid use disorder, they should be provided the appropriate care for addressing both of those conditions. And there's certainly ways to do that, and there are guidelines to help providers do that. And similarly, if someone is an injection drug user and they're not in recovery and they're not ready for that step yet, but they have a legitimate condition, they shouldn't be denied care. There are ways to more closely monitor those patients or work with them. And in building that relationship, it may present the opportunity in the future to then have that conversation with somebody about when they're ready for treatment, they have a trusted medical source that they can go to. So I think fundamentally it is about education, because maybe part of the issue is that there's some stigma on the provider side where they just see this as a bad person, and they're not showing up with the empathy and compassion. And so I think education can help with that as well.
I would agree. I think, dealing that everybody has a right to care and good care. I also think, again, these are really good opportunities to look at, particularly if opioids are not indicated for people with a history of substance use disorders who are actively using. But that doesn't mean that they shouldn't think about or offer other pain management strategies for folks to deal with those issues. We were talking about intervention opportunities before, and I think, given the magnitude of the issue, we really have to do everything that we can to engage people where they are and move them toward healthier behavior. And again, I think the last thing that we want to do is to deny people care, either for their addiction issues or their pain issues.
But it may also be challenging for a very well-intentioned provider to know exactly what the right thing to do is in some of these circumstances, and really doing the research and supporting quality care may be easier said than done.
And I also think it's really important to think about collaborative care models in those kinds of situations where a pain management specialist is working and consulting with an addiction specialist to really kind of co-manage that person's care. I think I know that there's not a lot of expertise out there around that, but there are people and places around the country that can, I think, really help support this kind of collaborative care work to deal with both people's addiction and pain.
And there are federal resources, the Physician Clinical Support System, both on the medication-assisted treatment side and on the opioid side, are grant programs funded by SAMHSA that provide a specialist consultation by phone, by email, to providers who are exactly in those tough clinical situations. And it's probably an underused resource.
Great, thank you. Well, as we're wrapping up, I want to give each of you the chance to give some final comments. I do want to personally thank you for such a really interesting conversation. It's really tremendous that we have such great federal leaders in general, and that they would come here to participate in this is really been fantastic. And Professor Federoli, thank you for joining, and to all your colleagues for putting together this report. Maybe I can show it to people. It's available online. But let me turn to you first for any closing comments that you have.
Sure. What has struck me about our conversation here today is the number of times the word opportunity has come up. And I really think that despite some of the troubling statistics that we see around this issue, there are a lot of opportunities for us to really act in a meaningful way to turn this around. So we talked about naloxone, we talked about PDMPs in particular, and both of those, I think, tend to be viewed as, PDMPs tend to be viewed as more of a law enforcement punishment type of tool. But as we talked about, there is opportunities there to intervene and help people who show up as potentially engaging in problem behaviors. Same with naloxone. It's a powerful drug that can reverse an overdose, but there's an opportunity there to intervene more comprehensively to assure that that person doesn't wind up needing naloxone again.
Great.
So a lot of positive things today.
Great. Dr. Jones?
I would just say I think that this report and the work that went into it and the conversation really underscores the comprehensive nature and the collaboration that has to occur to address the issue. When you look at the states who are starting to see success, it wasn't because their public health agency was the sole agency doing it or the public safety agency. It was really where they all came together and said, what part of this do we own, can we impact, and then working together towards a shared goal. So,
Thank you. Dr. Botticelli?
So first of all, I want to thank Johns Hopkins and Clinton Health Matters Initiative for undertaking this report. You know, part of my job is to make sure at the federal level we're paying constant attention to evidence-based strategies that we know that we have to implement at both the federal, state, and local level. So I appreciate all the hard work that went into this. But again, I will just go back to what Dr. Jones said, that we know this is a multifaceted problem. There is no silver bullet here, but that we do have effective strategies that we know can work. And I think the evidence has been gaining and the momentum has been gaining for these kinds of comprehensive approaches. So I really want to thank you for the opportunity and the work that you did.
Great. Well, thank you very much for joining us today.